We are live. You can proceed.
Good evening and warm welcome to the 36th webinar of Pediatric Orthopaedic Society of India. The topic of today's webinar is current concept in the management of osteochondritis dissecans of the knee joint in children. We are really fortunate to have world-renowned experts for this. We have three experts from USA, that's Mininder Kocher, Kevin Shea, Cliff Willimon. We have another expert who is, again, we consider him as an Indian, and that's James Uy from Singapore, and our own Rudraprasad from Bangalore. Before I hand over to Dr. Kocher for the lecture, I would give a brief introduction about each faculty. Mininder Kocher is Chief of the Division of Sports Medicine at Boston Children's Hospital, one of the famous hospitals in Eastern USA. He is also professor at Harvard Medical School. And the most interesting thing is he is president-elect of Paediatric Orthopaedic Society of North America. Kevin Shea is professor of Pediatric Orthopedic at Stanford. He is vice chief of research in pediatric orthopedic surgery. He is director of pediatrics in sports medicine. And the most interesting thing is he's also heading the Department of Quality Control and Management. Clifton Willimon is from Atlanta, and he's consultant in sports medicine at Children's Healthcare of Atlanta. He's also affiliated to Duke University and Emory University. James Uy, all of us know him. He's professor and chair of the National University of Singapore. He's head of Department of Orthopedic Surgery. And I would say that he's mentor of many pediatric orthopedic surgeons in India. His main interest is trauma and cartilage restoration. Our own Dr. Rudraprasad is attached to Indira Gandhi Institute of Child Health, Bangalore. He is visiting consultant at Sparsh Hospital and is director of Cure Clubfoot Project in Karnataka. About the format of this webinar will have two parts. The first part, we have a lecture by Dr. Mininder Kocher. After that, for the remaining 40-45 minutes, we will have our audience questions and answer by faculty and few cases for the discussion. You can WhatsApp your questions to Sandeep on the WhatsApp number 98230-63989. Before I hand over to Dr. Kocher for his lecture, I would just like to remind about our next webinar. The topic of next webinar is Growth Modulation Part 2. Before 4 months, we have a wonderful webinar on the growth modulation. A lot of queries, lot of questions were generated, and we decided to continue on the same topic. And next month, we will have a webinar on that topic. The date is 18th March, and the day is Thursday. So with this short introduction, I welcome all of you and hand over to Dr. Kocher for his lecture. Thank you. Over to you.
Thank you very much, Dhiren. Let me share my slides. Okay, I'm just going to go back to the beginning. Okay. So thank you, Dhiren. Thank you to POSI for hosting this webinar, and thank you to my friends and colleagues who are on the panel. I think it's extraordinary that POSI, this is the 36th webinar POSI has done. I think you are to be congratulated on that. That's making lemonade out of the lemons of the pandemic. My disclosures are shown here. I don't think there's any conflicts specifically with this talk. I wish I was there with you in India. Both my parents, I was born and raised in the US, but both my parents are from India. My mom from New Delhi and my father from Punjab. And so when I was a child, we would go back to India every summer to visit family. It's been great for me to reconnect with India largely through POSI, to coming to a number of POSI conferences. And I really appreciate my friendships with my colleagues in POSI and my family in POSI. Welcome from Boston Children's Hospital, where I practice, and Harvard Medical School, where we are faculty. I am the incoming president for POSNA, and we are having our annual meeting in May in Dallas. This will be a hybrid meeting with an in-person component. We canceled May 2020 meeting, so we're looking forward to starting to get back together in person. And I know it'll be difficult to travel, so I welcome you to join the online and virtual component of this meeting. I am looking forward to visiting India again for the POSI meeting. I know the Goa meeting has been moved to 2022 in February, and I really hope to be able to come to that meeting and see my friends in POSI. So we're going to talk about OCD of the knee, osteochondritis dissecans, and we're going to close the webinar with some cases and questions and answers, but I'll also start with a case. And so this is a arthroscopic view of an unstable OCD lesion. And how do we manage that? We have a variety of treatment options. And so that's what I hope we get from this talk, an understanding of OCD and the treatment options. I do think it's a good time to revisit OCD of the knee. This is OCD of the knee, has had a lot of changes. On the left, this is a slide from our institution from Dr. Green, probably in the 1950s or 60s, where OCD was managed with a bypassing brace to unload the knee. And a lift on the other side. Patients would be in this for about a year or so. That'd be hard to do today, I think. Imaging was with x-rays and bone scan. And if there was surgery for OCD, it would largely be open surgery with excision of the lesion. Nowadays, we're seeing OCD more frequently. We're seeing it in younger patients. We're seeing it in female patients as well. We have imaging with MRI, arthroscopic techniques, and hopefully more biologic options as well in the future. So the agenda for my part of this webinar in the didactic talk will go over the etiology, diagnosis, non-operative treatment, operative treatment, and then give you some thoughts in conclusion. So we're going to start with etiology. I think when we're talking about osteochondritis dissecans, it's very important to get our terminology correct. And we need to distinguish OCD from an acute osteochondral fracture, from a cartilage-only lesion, from an accessory center of ossification, variants of epiphyseal dysplasia, osteonecrosis. When we talk about OCD, we're mostly talking about a repetitive process that involves the subchondral bone and the articular cartilage and can lead to separation of the OCD lesion. There was a AAOS CPG work group on OCD of the knee. This was led by Kevin Shea, who's on this webinar, and Hank Chambers. And when you look at the results of this CPG, which reviewed all the literature on OCD, many of the findings were inconclusive or were consensus. So consensus in the absence of reliable evidence. And this just pointed out the lack of scientific literature in the area of OCD. This led Kevin to form a group of us together to start ROC, which is research in osteochondritis dissecans of the knee. So this was started in 2008. And the goal of ROC was to get people together so we can do better science and better research in the area of OCD of the knee. This is the ROC definition of OCD of the knee, published in 2013, a focal idiopathic alteration of the subchondral bone with risk for instability and disruption of adjacent reticular cartilage that may result in premature osteoarthritis. So if we look at the etiology of OCD of the knee, Koenig, whose picture's here on the right, in 1888, coined osteochondritis as an inflammatory process. Fairbanks, Smiley is shown here on the bottom. brought out the issue of repetitive trauma. Other etiologies have been proposed, including ischemia, an ossification abnormality, a genetic component, and other conditions as well, such as endocrinopathy. Probably the most likely etiology relates to repetitive trauma. This was a study published by Eric Edmonds, which was a review of the literature showing minimal evolution in our understanding of the etiology of OCD. Kevin Shea published this study looking at histological analysis of OCD specimens where there was mixed etiology, so some with repetitive trauma, some with poor blood supply, and some with unclear etiology. Another study by Kevin Shea pointed out that OCD may be related not just to repetitive microtrauma, but a discrete macrotrauma that resulted in bone bruising that later evolved into an OCD lesion. Tal Lohr and Eric Wall in Cincinnati, and Tal Lohr subsequently come back to Boston Children's Hospital, pointed out that OCD may be a disruption of the secondary physis. What do I mean by the secondary physis? Not the primary physis between the metaphysis and the epiphysis, but the physis that results in the growth around the epiphysis. And a disturbance in the secondary physis can lead to OCD-like lesions. I think it's best for now to just consider OCD as an idiopathic phenomenon. We don't clearly understand the etiology, and it may vary in patients, but likely does relate to some repetitive trauma in these areas. Diagnosis of OCD. So the diagnosis of OCD, I think, can be challenging because the diagnosis really depends on the stage of involvement. In early lesions with an intact articular cartilage, the symptoms may be very subtle. So just pain, stiffness, no single traumatic event may be related to overuse. Once we have instability of the lesion, the diagnosis is more obvious. We have mechanical symptoms such as catching, locking, and swelling. Look for an external rotation gait or pain with internal rotation, the so-called Wilson sign. You may have tenderness over the area of involvement, swelling, and pain with provocative maneuvers. This shows the locations in the knee. The most common location is the lateral aspect of the medial femoral condyle. This was in about 2/3 of patients. About 33% of patients had the lateral femoral condyle, so the second most common location, and about 3% of patients had OCD of the patellofemoral joint, the patella or the trochlear groove. OCD can be diagnosed on x-rays, and when you get x-rays in adolescent patients with knee pain, I'd encourage you to routinely include the notch view, so the flexion AP view, because many of these lesions are more posterior on the femoral condyle. This is the same x-ray, AP, and the notch view clearly showing the OCD lesion. You can classify OCD based on its location, the most common again being the lateral aspect of the medial femoral condyle and more posterior. There is a classification system based on X-ray by Berndt and Hardy, which is infrequently used now. Bone scan was very popular in the 1980s for looking at OCD and was used when I was training in the 1990s as well. And there is some advantage of bone scan. Bone scans giving us information about blood flow and osteocyte activity. Cahill from Chicago recommended following OCD every 6 weeks with a bone scan. And there were some bone scan features that were found to be prognostic of healing with non-surgical treatment. The Cahill classification of OCD on bone scan is shown here, but again, this is infrequently used. So MRI has largely supplanted bone scan, and I find MRI very helpful in looking at OCD lesions. A good MRI can give you information about the articular surface, stability of the lesion, how much edema is there, how established is the non-union between the OCD bone and the underlying bone. We found MRI to be very sensitive and specific for OCD, and the group from CHOP found MRI features that were prognostic of healing. This classification by Hefty, Fritz Hefty from Basel, Switzerland, is the most frequently used. So stage 1 intact cartilage without margin. Stage 2, intact cartilage, but the lesion's marginated. Stage 3 is partial dissection. Stage 4, complete dissection, but the lesion is in situ. And stage 5 is a free fragment. Here is an AP X-ray and a coronal MRI, and you can see how much more information you get on the MRI. This would be a hefty stage 2 lesion with intact cartilage, but clearly demarcated. Lateral knee X-ray with a sagittal MRI. So again, this is now a stage 3 lesion where you see some step off in the articular cartilage at the anterior aspect of the lesion. What other features are we interested on MRI? These are some of the features that we've highlighted in the ROC study group. So one is the contour of the lesion. Is it normal? Is there an offset that's concave going in or an offset that's convex coming out? What's the interface between the cartilage and the bone in the OCD lesion? Is there no increased signal? Is there focal increased signal? Is there a linear signal? Again, this is between the cartilage and the bone of the OCD lesion. What's the interface between the lesion and the rest of the bone, the underlying bone? Is it irregular? Is it linear? What does the bone fragment look like? So is the bone fragment one piece? Is it fragmented? What does the quality of that bone look like? How about marrow edema? Is there minimal marrow edema? Is there crescentic edema around the OCD lesion? Or does this edema now extend into the whole femoral condyle? Stability of the lesion. So how can you tell if the lesion's stable or unstable? If there's a cyst, that has good sensitivity. If you see fluid behind the lesion that matches the fluid in the joint, that's a sign of instability. And then finally, classifying the lesions based on arthroscopy. So this is the ROC Arthroscopic Classification system that was developed and validated for describing these lesions arthroscopically. So we have a cue ball lesion, which is essentially normal arthroscopically, but the action's happening behind the cartilage. And we have a shadow lesion where there's a shadow of the lesion. This is often helpful to turn your arthroscopic light source down to see this. Is there a wrinkle where there is a buckle or a fissure in the articular cartilage? Those are all called immobile lesions. Is there a mobile lesion, which is a locked door? So there's a fissure in the cartilage, but when you probe it, it does not open. Is there a trap door? So when you probe it, it opens and closes like a trap door. Or is there a crater? So this is a loose body with an underlying osteochondral defect. So that was diagnosis. Let's move to non-operative treatment of OCD lesions. So non-operative treatment of OCD lesions, I think, is indicated for stable lesions with intact cartilage in patients who have open growth plates, what we used to call juvenile OCD. And that's because there is healing potential. The treatment varies. Clearly, it involves activity restriction, so stopping the impact sport. If they're very symptomatic, we often add crutches to unload the area, perhaps immobilization. Perhaps we want the knee to move because that's good for cartilage nutrition. And we and others have been looking at the use of an unloader brace. The length of non-operative treatment has varied in the literature from 12 months, even 2 years, down to 3 months before you determine whether a lesion is healing or not. Non-operative treatment can work. These are x-rays of a patient treated non-surgically that went on to heal without surgery, an MRI scan showing resolution and healing of the OCD lesion. The problem, though, is not all the lesions heal. Cahill in this series in 1989 looked at 92 knees with prolonged treatment, so 10 to 18 months of activity restriction and protected weight bearing. And he found that about 60% of them healed, about 40% of them went on to not heal. And the problems with treatment is it can be very difficult to restrict these very active kids and their families from sports. So compliance can be a problem. They can get older during non-surgical treatment while their healing potential decreases. Also, there's a lot of variability in terms of what we consider non-surgical treatment. This is what a study we did prospectively with CHOP, where we looked at juvenile OCD lesions, so open growth plates with intact articular cartilage. All were treated with activity restriction and physical therapy. One group had casting in addition, one group had unload or bracing in addition. The patients were all followed at regular time intervals. And we found in this study, which was 112 knees in 70 patients, that 62.5% of them went on to heal. And when we looked at predictors of non-healing, we found that age was important. So older patients were less likely to heal. Lesion size was important. Bigger lesions were less likely to heal. Symptom duration, so patients with longer symptom duration were less likely to heal, and those with a more advanced MRI stage, so stage 2 or stage 3 lesions, were less likely to heal. We found a trend to higher healing rate that was not statistically significant with unload or bracing. Eric Wall and the CHOP group published in JBJS a prospective cohort study, 47 knees and 42 patients, also with stable lesions, treated non-surgically, and they similarly found 66% of these patients progressed towards healing. Factors that they found were important included the patient age, the lesion size, and the duration of the presenting symptoms. So a summary of those 3 studies, Cahill, Ars, and Eric Walls, would say that non-operative treatment has probably a 60 to 65% healing rate. Skeletal maturity is an important factor. Age of the patient is an important factor. Size is an important factor. The location of the lesion, so medial lesions more likely to heal than lateral lesions, and the chronicity of the OCD lesion. These are all probably important factors in their prognosis of healing with non-surgical treatment. So let's now move to operative treatment. And so if we've said that non-surgical treatment can work for stable lesions with intact cartilage, we proceed directly to surgery for unstable lesions or detached lesions. We may also proceed to surgery for those that fail non-operative treatment. And we think about surgery in patients who are skeletally mature because they have less healing ability. This is the menu of treatment options in terms of surgical treatment for OCD. We can drill the lesion, fix it to get healing, remove the fragment, and do chondral resurfacing of the lesion. So let's start with drilling. What's the rationale for drilling? This is to enhance vascularity of the lesion. We typically do this for stable lesions with an intact articular surface, often done in concurrence with fixation. The approach can be transarticular, so through the articular cartilage as shown above, or retroarticular, so behind the lesion without violating the articular cartilage, under fluoroscopy without violating the physis. We've done a randomized clinical trial of transarticular drilling with retroarticular drilling that Ben Hayworth, my colleague, is the primary author on, and those results should be presented this year. We published a while ago in 2001 on transarticular drilling in 30 knees. These were patients with intact articular cartilage, hefty stage 2, that failed non-operative treatment of minimum 6 months. And we found that all 30 of these patients went on, sorry, all 30 of these patients went on to healing. Operative treatment, what's the rationale? To provide stability to allow for fracture healing. So this is indicated in unstable lesions or detached lesions, and these can be fixed either antegrade or retrograde with a variety of hardware. We published results with fixation in 26 knees and 24 patients, average 4.3-year follow-up. We found in this series that 85% of these lesions went on to healing. And that was our main takeaway point, was that even the unstable lesions that were detached went on to healing, all 6 of them. So our preference is whenever we can to try to fix the lesion to keep their own bone and articular cartilage. What about excision? I think sometimes we are forced to excise particularly when it's a loose body and chronic. There's often a mismatch between the size of the lesion and where it came from. The cartilage may be bad on the lesion, or it may be avascular. We know that excision alone, Alan Anderson showed us that the prognosis is poor because these are large areas of the weight-bearing zone. So typically then this requires chondral resurfacing. So chondral resurfacing are attempts to bring cartilage back to an area where there is cartilage loss. Chondral resurfacing techniques are shown here, including microfracture. Microfracture is often challenging in OCD patients because you do not have intact subchondral bone, and the lesion size is quite large, where microfracture does not do as well. We have mosaic plasty, so this is autologous osteochondral plugs from the knee placed into the lesion. We have osteoarticular allografts. These are typically fresh osteoarticular allografts. And then we have techniques with ACI, autologous chondrocyte implantation, which has moved to MACI, matrix autologous chondrocyte implantation. So these are typically done as a salvage when there's loss of cartilage in a symptomatic patient. The prognosis, specifically in younger patients with OCD lesions only, is hard to determine. So some thoughts in conclusion. This is sort of my treatment approach to OCD, juvenile OCD of the knee. If it's an early stage lesion with intact articular cartilage, we'll typically try non-operative treatment. This means activity restriction, physical therapy, potentially bracing. And then if that fails, that goes to drilling. We typically get an MRI initially and repeat an MRI after 3 months of non-operative treatment. Even in these stable lesions, if they have risk factors, so a large lesion, a subchondral cyst, a lesion of the lateral femoral condyle, an older patient, we may consider, after shared decision-making with the patient and family, proceeding directly to drilling. Stage 3, 4, and 5 lesions, so these are unstable lesions. If there's a fissure in the cartilage, the wrinkled rug, or the locked door, typically we're treating this with drilling, bioabsorbable tacks. The stage 4 lesion, which is the trapdoor lesion, this is often done through an arthrotomy. We may be bone grafting, and then typically I use a bioabsorbable variable pitch screws. And then the stage 5 lesion, so the loose body lesion, if we can, we try to fix this, put it back, often with bone grafting, often with metal screw fixation that we come back later to take out. Sometimes we excise these and proceed directly to chondral resurfacing. So I think you do need a bag of tricks in your medical bag for treating OCD lesion. Understand when non-operative treatment is indicated. And then for fixation, you need a variety of surgical techniques. Salvage as well, chondral resurfacing techniques. I think for many OCD lesions, because they're large and they also involve the underlying subchondral bone, we often now are doing osteochondral allografts to replace both cartilage and bone, but we really don't know the long-term results of this in younger active patients. I do think we need to be thinking about the long-term results of this. These are cartilage lesions we're treating in adolescents. What are they going to be like as adults? Sometimes we see these horrific lesions, such as this lesion, which is almost the whole back of the lateral femoral condyle that failed prior treatment. You can see some screws here loose in the knee. And so what is the long-term prognosis for this patient? I think the future holds promise. So we need a better understanding of the etiology of OCD. We need an animal model. We will have better equipment, including bioabsorbable equipment, better understanding of biological treatments, including growth factors, stem cells, how these may play a role in OCD, and then better chondral resurfacing techniques, including scaffolds, growth factors, even 3D printing. One approach would be to stop these lesions before they start, so prevention of OCD lesions. We have efforts with Stop Sports Injuries, not just for ACL, but for overuse injuries as well in our kid and adolescent athletes. We have specific interventions. This is the McKaylee Center for Sports Injury Prevention we have at Boston Children's Hospital, where we have injury prevention evaluations. And then I think we can learn from our veterinary colleagues. This is one of my very close friends, Wayne McElraith, who's an equine arthroscopic surgeon at Colorado State University. And I get to operate with him periodically. And we see a lot of OCD in the stifle joint of the American quarter horse. So this is a horse often used in barrel racing. And this is an arthroscopic procedure in the stifle joint of a quarter horse. I'm showing bioabsorbable fixation with pins. But in these horses, we've been able to reduce the amount of OCD in the stifle joint by regulating their amount of activity, warming up the horses, warming down the horses, looking at their nutrition, making sure they have plenty of rest and sleep, minimizing their stress, and early stem cell injections when they're showing any signs of lameness or any edema on MRI has made a dramatic effect in the quarter horse. So maybe we should be treating our young athletes more like quarter horses. I usually close with a family picture. These are our horses. This is Joe on the left and Falsterbo on the right. So once again, I'd like to thank POSI for the opportunity to talk about OCD and thank my colleagues on the panel. And I look forward to questions, answers, and then going through some cases. Thank you.
Yes, before we have a discussion, I would like to ask Rudraprasad. Dr. Rudraprasad, what do you think, like what Dr. Kocher said, is it possible to practice in India? Everything is possible to practice in India? Or what are the challenges which you face in your practice?
Yeah, excellent presentation, Dr. Mininder. It was very informative, especially the classification, which is really useful for decision making. So in India, coming to the Indian perspective, Indian practice, the most difficulty is the two-stage procedures. See, for example, if we are planning for an ACI or a MASI, so most of our patients, they don't agree for a two surgery. So if we are taking up one patient for a surgery, means they want a solution at that time. So that is one constraint. Number two, these procedures again are very expensive. See, cartilage culture, definitely I don't know about the other countries, but certainly even in India also it costs around 1.5 to 2 lakhs Indian rupees. It's quite expensive. So that is one constraint what we have. And certainly the mosaicplasty and the fixation. So those two are definitely possible and are good options. I think the fixation is one thing which we often neglect in our practice. We think that looking at the lesion, especially during the arthroscopy, everything looks very scary, especially the MRI, which shows a lot of edema in the subchondral bone, and it looks, it may not take up. These kind of doubts always are there. But for a juvenile lesion, it's better to try fixation, or always we should keep it in mind. So regarding the fixation, again, these bioabsorbable screws are not freely available in India with every suppliers. So what we get usually very freely is the Herbert screw or a headless screw, which are threaded, which I usually commonly use these screws quite often, but only thing is we have to make sure that they are sunk inside the cartilage so that they don't cause any arthritis, abrasion to the cartilage. So the last two options are a little difficult in our country.
Yeah, I think those are excellent points. You know, I agree completely with the point about trying fixation, because if you fix it and it heals, they keep their own bone and cartilage, and that is likely preferable. You know, in our study, we found 85% of the lesions treated with fixation went on to heal, and other studies looking at fixation have shown high rates of healing as well. So I think it's definitely worth trying. You know, there are some lesions that just are not amenable to fixation, but I think most of them are. And I actually think the metal fixation is a really very good option. You know, I think it's strong fixation. You do have to bury the heads. I don't mind coming back and having to take out, because then you can see how the healing and what the cartilage looks like. But I think the Herbert screws are an excellent option as well.
It's just a small doubt about this bioabsorbable pecs. So they're certainly instrument dependent, and quite often I found in few cases when I attempted, it's difficult to pass them exactly in the plane where we wanted, and sometimes they break, and we can't really judge. Screws may be fine, but the pecs are not in favor for me. What's your opinion, Mininder?
Yeah, I think that the tacks can be helpful. They're not as strong fixation, so we don't use them typically in a lesion that's very unstable. So it's often in that stage 3 lesion or a lesion that has a little bit of movement. I think if you bury the head of the tack underneath the articular cartilage, that can help prevent it from backing out. But if the lesion doesn't heal or takes a long time to heal, the tack can break. It can become loose in the knee and cause a synovitis, a reaction in the knee with swelling. So I think they can be used, but really just in appropriate circumstances.
Okay, Kevin, now can you take over the question part, sorry, the case discussion part?
Yeah, great, Darren. Let me just swap screens here. And boy, Min, wonderful talk. I've heard you give that version of that talk a few times through the years, and it keeps evolving and updating. And so it's great for me to have the benefit of a wonderful education update, Min. So beautiful talk, slides and everything. So let's, okay, let me make this slightly bigger for everyone. And Darren, is the slide deck showing up okay for everyone?
Yeah, but can we go in the full screen mode?
I probably can't, because when I'll try to make this smaller. The challenge I have is I've got a multiple monitor display, and when I go to full screen mode, it doesn't work with Zoom, unfortunately. So
Okay.
Sorry for that conflict. So we'll go ahead and continue with some case discussions. And I, like Min, I have no conflicts relevant, but you can check the Academy's website, but I have no financial conflicts relevant to this. And Min already did a wonderful job introducing our panel, so it's great to move forward. We're going to talk a little bit about the stable versus unstable lesion, which I think is the real decision point we have to make a lot of time. Talk about indications for drilling and fixation, and also we'll touch on some advanced cases that the less invasive approaches won't work. We have 5 cases, and we're going to try to go through 3 to 4 minutes for each panel member present a case, and we'll save 3 to 4 minutes for questions, and we have a 6th bonus case if we have time. So as Min said, we have the classification system by the Rock Group, and we try to break them into the stable or immobile category, as well as the unstable or mobile category. And I like this is one of my favorite pictures about this. I think of a stable OCD, if you will, as it's a little bruise in the apple, right? We've all seen an apple with a bruise, but the skin is intact, and that apple's probably still pretty good to eat. And then you have the major break in the fruit. The skin's broken, the quality of the fruit's not so good, and probably the apple's not so good either. And so I think of stable versus unstable as kind of this slight bruise versus a major dent and break in the skin of the apple. So we've got Dr. Willimon here, and he's got a wonderful illustrative case of healing, and I think a somewhat difficult case. So Cliff, I'm going to go ahead and you tell me when to advance, and I'll just advance the slides for you. I'll go on to your first one right here. So go ahead, Cliff, you take over with the microphone and tell me when to advance for you.
All right, thank you. Thanks, Kevin. And thanks again for hosting a wonderful webinar from POSI. So this is a 13-year-old male who's a soccer player in one of the pre-professional tracks with a professional sport soccer club. He presented reporting 4 months of lateral knee pain, and this was in April of 2019. And in his radiographs, you can see he has a large OCD of the lateral femoral condyle. He's an otherwise healthy young man and is playing at the highest level of soccer along a professional track in the United States. We can go to the next slide. So given this and the chronicity and the findings, an MRI was obtained. And you can see there's quite a large OCD of the lateral femoral condyle. It shows lots of concerning signs, frankly, of evolving instability. We can see a tremendous amount of bone marrow edema, cysts within the base and the progeny fragment, and on the medial aspect, an early chondral fissure. Next slide. So I had an interesting conversation with the family, and this was the unique twist. And I think as seeing a lesion of this side, there are lots of risk factors. We know lateral sided lesions don't heal as well. That was a large lesion and showing early instability. The other factor that we have to always consider is the patient and their families and their preferences. So we talked about it and options. The patient's father actually had polio as a child and had complications related to his treatment as a child in limb surgery, and so they were very hesitant to have any kind of surgical procedure, and so they made the decision to proceed with non-operative management. And so his father was quite direct and made sure that his child used crutches for 3 months, and it was the most impressive matter of compliance I've seen in a patient, I think. And we also placed him into a lateral unloader. And so after 3 months, we have follow-up x-rays, and we can see early reossification and healing proceeding really from lateral to medial. And so we continued along in November. You can see further healing. Given the size of the lesion, I obtained a follow-up MRI. I was worried about chondral progression, but we can see the cartilage seems to be well aligned. And then in January of 2020, subsequently, you can see continued healing. He was clear to be in light soccer training at that time and conditioning. And next slide. And then in June of 2020, he's completely asymptomatic, nearly completely resolved. He's actually on the schedule today for another follow-up visit. I was hoping, I tried to get them to come in a day early, but I couldn't quite get mom and dad to come early enough. So, but I think it's a great example of the potential for healing in even a case that I frankly was very skeptical about.
Yeah, and it's a great case, Cliff, and I share your skepticism on that one. But I think the saving grace is his growth plates seem to be at least a couple years of growth remaining, and that may be what saved him here. But I love, Dr. Kocher, I love your thoughts about, and you alluded to it in your previous talk, about factors that you consider when you think about operative versus non-operative treatment. This is obviously a quite large lateral femoral condyle lesion, which gives most of us a little bit of anxiety, but love your thoughts, Min.
Yeah, that was a really interesting case, Cliff. And I think that, that did really look like a bad actor lesion on initial presentation, sort of lateral, large, a lot of findings on MRI, edema, some fissuring of the cartilage. I didn't see subchondral cysts. The symptom duration seemed like 4 months, so it wasn't like a year or something like that. But I think many of us, would do that shared decision-making approach, but would probably be leaning towards initial surgery, given how bad that lesion looked. It's interesting, though, that the shared
Min, we've lost your audio. At least I've lost your audio. Cliff, can you hear Min? I've lost him.
I cannot.
Sorry, Min. See if you can reconnect, Min. We've lost your audio and video. Hopefully you can hear us.
While we're reconnecting, yeah, it was a great example of shared decision making, and I did recommend surgery actually, and despite that, and the patients and families, they all have their own life experiences, and so we followed him closely, and but it was a good example of maybe one that did have a chance to heal. We thought otherwise. So.
Yeah, Cliff, sometimes I feel that patients and families don't read the textbooks. They're not supposed to heal, and if they'd read the textbooks, he probably wouldn't have healed. So, yeah, great case, and I'm quite surprised. I would have followed, I think, a similar thing, but I think as Min and others have emphasized, that shared decision making. I tell patients all the time. They ask me what they should do, and I say, I'm not here to tell you what you do. I'm here to help you make a decision. I'm trying to give you as much information as possible, and you make, and I want patients to make the decision and own the decision. But I think that's a great case of listening to the family, and I think you it was a little bit of an outlier. Well, nice case, Cliff. It's a nice segue into our next case. It's a little more.
Sorry, I think, am I back on, Kevin? I think I bounced out.
You did, man. Sorry, man. You were just talking about, you were a little concerned about it, so we sort of filled in for you. But why don't you give us your perspective again? Let me go back to that slide. But yeah.
No, I just thought it'd be really interesting when you see him tomorrow, maybe to get an MRI scan as well. Because, you know, the MRI healing is really hard to understand, and it certainly lags the X-ray healing. And it would be interesting to see what it looks like with such a good X-ray, what it looks like on MRI. That was my only comment. Great.
Well, we will go on to the next case and kind of escalating up maybe the complexity. It's a 13-year-old, also a very high-level soccer player, 7 months of pain, and had the unloader brace, activity restriction, a total of almost 5 months, and unfortunately had not improved. And as Min mentioned earlier in his talk, you can see on the slides, the AP view is sometimes gives a suggestion, but the notch view will be the winner for many of you, or you'll struggle to see it, but you'll get a notch view. So I really encourage people, as Min suggested earlier, get the notch view. Here is this 13-year-old female's images. And once again, 5 months of treatment, activity restrictions and loader brace, open growth plates, and unfortunately hasn't improved. So I'm going to throw a question here at Cliff, you know, with that 7-month history of pain and not improving, but the MRI showing intact cartilage. Any thoughts how you might approach this lesion? And if you approach it with drilling, how much you approach it?
Yeah, so, you know, 7 months of non-operative treatment, of good treatment, unloading and activity protection. This is certainly one that I would be recommending to consider operative treatment. Certainly, you know, when these progress and it becomes an unstable lesion, the outcome reliability of any treatment declines. And so I think we've crossed the threshold. So I would recommend operative treatment. Typically, I would approach this arthroscopically, performing a diagnostic arthroscopy to assess the cartilage status, to look to see is it immobile or mobile or stable or unstable lesion. We certainly know that retroarticular or transarticular approaches are successful. I typically perform retroarticular drilling using 6-2 K wires. I think there's some technical tips and pearls with this, using parallel guides, using fluoroscopy, as well as marking the anterior and posterior extent of the lesion with your with fluoro and with a pen, because I think it's very easy in a retroarticular drilling fashion to not cover the lesion. So taking special precautions to make sure you cover the entire lesion with your drilling stimulation.
Yeah, that's a nice summary, Cliff. And what's nice is, you know, Ben Hayworth, Min's partner out of Boston, and the Rock Group has done a nice prospective comparative trial. It's we're very proud to see Orthopaedics can actually do randomized clinical trials, and they're going to present it this year. So more to come on retro versus transarticular. As Min said earlier, with open growth plates, you know, subchondral bone drilling, the prognosis for healing is, the worst study I've seen out there is about 80% healing, and Min's study had the 100% healing, and most studies are somewhere between 80 and 100%, both transarticular and retroarticular. Adult patients, the results probably aren't as good. Just diagrammatically, once again, Ben's very nice randomized clinical trial, kind of transarticular versus retroarticular. This patient, I did undergo a transarticular, and one comment I always make about transarticular and retroarticular is you want to avoid the physis, especially in kids that have loss of growth remaining. So this child was treated with transarticular drilling with 0.045 or 1.1 millimeter pins, the smaller K-wires, about every 5 millimeters apart. And then Dr. Prasad, I'd love your thoughts about, if this was a patient view, any thoughts about how you treat them post-operatively and how you might counsel the family about when they might go back to sport.
Yeah, as Cliff was mentioning, certainly fixation, I mean the drilling just to stimulate the bone marrow is an ideal option. So post-operatively, certainly in our country, in my practice, what I do is I put them strictly in a knee brace. Because non-weight bearing advice, I'm not sure how many of our patients will follow here. So either I will put them in a plaster cast, because this is a most important stage, especially for first 6 weeks. So then probably if there is an option that I can use a knee brace or a plaster cast, whatever, I'll put that for about 3 weeks. And then obviously by 3 weeks, there will be some amount of a stiffness. They won't be able to move around or take the weight on that limb very soon. So, but the advice will be for 2 months, if they can monitor weight bearing strictly, that will be my advice. And regarding the healing part, I certainly will discuss with the family that there is a fair chance of healing in this particular case, but still they need to be ready. If there is no healing, probably we may have to come back and have a relook, and then if required, some other procedure we may have to choose it. And regarding return to the sports, certainly I will not allow this child to play before 1 year in my books. So that's what I practice, because whatever said and done, generally only way we can assess the healing is an MRI scan.
Yep.
Post-operatively.
Right.
So because clinically they will do well in terms of any range of movement, exercises and everything, but before taking them to sports, probably I will do an MRI scan and assess there, and then that will be minimum 1 year, is my opinion.
Well, it's great to have those comments, and I'll just advance quickly here and show you this. This patient actually had significant healing by X-ray at 3 months. In fact, sometimes the healing is so good on the X-ray in 3 months, I may not get an MRI, but most of the time I get an MRI before letting them go back to sports. And you can see on the left is the pre-image, on the right is at 3 months. And so pretty remarkable MRI healing at 3 months. And I let her go back to soccer at about 4.5 months. And I don't always keep them out a year, but I tell families, we'll let them go back when there's signs of healing. And some people heal rapidly, 3-4 months, but some people, in my experience, take longer. I typically don't immobilize them. I try to keep them on crutches for 4 to 5 weeks, maybe 6 weeks post-op, and then I'll go back to low impact physical therapy supervised programs. But there's long-year follow-up on her. She actually, she was treated at 13, and she played a Division I college soccer 2014 to 2018. So I had a nice recovery and started 3 of 4 years at varsity Division I soccer. So a nice outcome for this patient. So we're going to go into a slightly, maybe a little more interesting advanced case. Dr. Wee, I'll advance the slides for you. You just give me the cue, but you take over. This is your case. You're on mute, James. Can you come off mute?
Okay, thanks. Yeah, so this is a 14-year-old girl. She had bilateral knee pain for 3 years. Then only they saw like came for treatment. And X-ray was done. There were MRI. Next slide. So next slide, please. Yeah. So MRI, I would say this is almost, you can see a lot of edema, and there's also some fluid in between the progeny. Do you still call that progeny fragment against the host fragment? So I didn't think of it so positive, but nonetheless, I still treat it as a sort of like immobile, stable category. But clinically, patient has a touch of varus. That's why I went on to do a long leg film. And then long leg film had this 6 degrees varus. And in fact, I discussed, I did a small poll with Ted and Kevin and Jim Carey as well. And very interesting, half of them say we should do because patient already a facial closure. So half of them say we should do osteotomy. Half of them say, no, we should just do the OCD. So it'll be very interesting. So next, so for both knees, can you just play the video? Yeah.
I'm going to be ready. It will take 1 or 2 minutes for me, but there are 6 minutes before it.
So this is a very, I don't know whether I should call this a wrinkle in the rug or not, but nonetheless, I definitely think it's not the trapdoor or any unstable thing. That's why I went on to do next, either you call it retroarticular or transosseous drilling. So this is at 1 year MRI, post-op MRI. I must say for both left and first the right knee and then the other left knee, there was some healing on the, I would say MRI for T1, but T2 and the fat suppression didn't look as good as it should be. And then next is the left knee. Next slide. Kevin, next slide, please. Yeah, okay, so left knee as well. You can see that I thought the edema was still there. But nonetheless, after somehow with that MRI, patient's symptom improved tremendously. And she was a avid volleyball player. And then very fortunately, just even with pandemic, so why I chose this case, because next slide, I saw this kid like 2021, so nicely in maturity, went to college, and she's the vice captain of the volleyball team. But well, maybe because OCD, she isn't the captain. But nonetheless, you can see the X-ray. X-ray, there were still, you can see the defect at the region, but can you go to next slide? But you can, and on lateral view, you can still see the divot appear there. And I asked her to do MRI, but parents refused because they say that, you know, if I can play competitive volleyball, why are you asking me to do MRI and costing money? So my question here, why I presented this case is really, I think there's a discrepancy between what you saw on X-ray and what we saw MRI, and also with symptoms. So that's something I try to sort of circumvent with myself. Thank you.
Well, great, very nice case, James. It raises a lot of interesting issues. And I'm just going to maybe ask the question for you, James, is I know sometimes we see these patients who are 2 years from growth remaining, and if they're in significant varus or valgus, do you ever use guided growth in your patients, like someone who might have OCD medially and significant varus? Is that something you ever use?
No, definitely, because I love to use them. You know, I use them for OCD, and you know that I also using them for even patellar instability. I used to do for whatever valgus, I do guided growth as well. So I'm a really big fan of that. Yeah.
Great. And do you have any type of system you like to use, James? Do you use screws? Do you use screws and plates? Do you do a bone type procedure? How do you like to do your guided growth?
Oh, I think almost exclusively we use a plate, yeah, or quartz plate, yeah. Depends on the size.
Well, in this case, and in other cases, we see, you know, sometimes their growth is almost done or done completely. And Cliff, Dr. Willimon, any thoughts about role of osteotomies in OCD, perhaps in this case or other cases in your experience? I know you treat a fair number of young adults, so you probably see a lot of patients who we've missed that window of growth plate modulation.
Yeah, certainly as the window is closed or is closing, osteotomy has a role. Typically in the assessment of new patients with OCD, a long alignment film is kind of a standard part of my radiographic workup. And then with that, I think it depends on the severity of the OCD. If we're pursuing non-operative treatment and we see reassuring signs on the MRI that it's a stable lesion, then not so much, but I would certainly use an unloader brace. But when we're proceeding into cartilage restoration procedures, which is typically more of the common role where it's not a salvageable lesion, then I do use osteotomy. I think it's important to consider the overall limb alignment, but it's still important to measure your angular measurements at the knee, looking at the LDFA and the medial proximal tibial angle as well. Because sometimes, although we may routinely perform a DFO to unload the lateral knee, it's important to make sure that your tibial anatomy is not problematic. So,
yeah, great summary there. And you know, one of the things I think we psychologically dealing with families, this is a big hit when these kids have these diagnoses. And I think sometimes talking about a major procedure when you first meet the child and family is such a shock to them. And so I'll frequently tell patients there may be a spectrum of things that you might need. But we're probably going to be following your child for 5, 10 years or longer. And sometimes one simple intervention doesn't work, but I try to prepare families from the beginning, but not necessarily jump to a major surgical recommendation, because I think some of them are shocked. And to jump to that major surgical recommendation in the beginning is hard, but as you build rapport and get to know them, that might be an easier conversation going forward. So
yeah, I completely agree. You know, typically OCDs have been evolving in the patient's knee for quite some time.
Yeah.
And so realizing that this is a chronic problem that unless they have a loose body and a locked knee, but typically you do have time to continue to develop the rapport and work through that conversation with them.
Yeah. And I think that sometimes, as Eric Wall told me years ago, he looked back on 20+ years of treating OCD, and for patients who didn't heal with non-operative treatment or drilling, the ones that didn't heal, the average number of surgeries that those other patients required to heal was about 3 operations. And so I think telling families sometimes that it might be more than one operation. If you tell them ahead of time, it's an explanation. If you tell them afterwards, it's an excuse. And I learned that from Eric Wall. So, well, we're doing nice. We're keeping a nice pace here on our cases.
Sorry, Kevin, can I add in here? So does it?
Of course, go ahead.
Yeah, I get a take-home message from Cliff is that if there is more for unstable and therefore some kind of cartilage restoration procedure, then we'll be more open or have a lower threshold for osteotomy. Whereas it's just purely treating OCD, then maybe we hold back a little bit.
Yeah.
Yeah, I would agree with that too, James. I think that's right. If you're doing cartilage restoration, I think an osteotomy is very important to unload that area. But I do like Cliff's recommendation of getting long leg films. And we've been doing that now in our OCD evaluation. I think the other thing that's important in the evaluation that also came up in your case, James, is to get x-rays of the other knee. I didn't used to do that routinely, and now I do, to look for an asymptomatic OCD on the other side, which may be present in 20% of cases.
But my case was interesting. I see she actually presented with both, but bilateral pain. Well, just 2 days ago, I saw a 6-year-old boy with OCD MRI, and I did the Rosenberg and view, and then actually got it positive. And I did the X-ray on the other side as well. A 6-year-old bilateral. I'm like, wow, shocking.
So how do you figure out if that is a OCD or a ossification variant in a 6-year-old?
Okay. So it's a very clear with edema, and okay. After this, I can send you the film. I'm trying to do more and more study. I was really excited by seeing that kid. Yeah.
Yeah.
Well, great. Well, we're making a nice progression here through our cases. We got 2, possibly 3 more to go. So Dr. Prasad has a really interesting case here. So Rudra, I'm going to advance the first slide and turn the microphone over to you. You just tell me when to advance. So here's your first slide.
Yeah, this is a 12-year-old boy. This is way back in 2007 and 8 during that time. So this boy came with a history of pain and recurrent effusion. And then we did an MRI. This was the lesion. This was quite unstable, an arthroscopy, and then it was completely almost separated, and there was hardly any connection of cartilage in that area. Next slide, please. Kevin, go to next slide.
Sorry, Rudra, lost my sequence here. Here we go. There we go.
Yeah, that's the one. So it was quite a big lesion. It's almost like 30 by 25 millimeter in size. And, the options we had those days was, we never had these ACI and MASI procedures available in India so freely those days. And ORTS, of course, was an option for me. But the synthetic grafts were in vogue those days. There people were from these companies, they were just introducing and telling that this is a very easy technique and things like that. So we wanted to use it, but we gave the option to the parents and they agreed. And we used a synthetic graft by Smith & Nephew then. And go to the next slide, please. This is the lesion in the arthroscopy picture. The one next to the one on the right side was after the debridement. This is the size of the lesion. Yeah. So this is after the debridement, the one on the right side. And you can see the depth of the cartilage defect also. It was more than about 3 millimeters. Next slide. And this was the lesion size, and we went ahead and, so that is the cartilage graft sizer, and then the preparation of the area for the synthetic graft insertion. Next slide. Then we did a mini arthrotomy, and then this is how it is. Only problem with this graft was it would easily get detached from the bony component, whatever the synthetic hydroxyapatite crystal or whatever they had. The cartilaginous portion, the collagen complex, was easily getting detached. So we were very carefully, we did it. It was quite expensive. Go to the next slide. So this is his MRI. This is after about 2 years. Immediate post-operatively, the short-term results were quite promising. The boy became fine and he was asymptomatic. But still, if you see, as Mininder was telling about this, convexity which is not maintained that well, I always had a concern about that. But now, go to the next slide. So now I just recently met him, and he's not that happy at all. So he's having frequent pains, and there is a significant medial joint line narrowing, and he's slowly getting into arthritic stages. The reason why I put up this is to, the synthetic grafts which we tried was not really a good option. Probably I should have done an oats those days. So this was a lesson for me, but I don't know if anybody has any experience with the synthetic graft can share it. And now, of course, I'm not hearing from any of these manufacturers this availability. Any inputs from you guys there?
Yeah, Rudra, I know the group at Hospital for Special Surgery was using those same grafts. To my knowledge, about 8-9 years ago, they stopped using them for cartilage gaps, whether traumatic, osteoarthritic focal lesions or OCD, because I think their experience was similar to yours. They weren't getting the positive results that they had hoped. I'd love to, both James and Min, if you guys might tackle this, James first, Min second. Love your thoughts about, sounds like this patient is symptomatic, maybe a little joint narrowing, but still very young. Any thoughts, James, about how you might approach this patient?
So I'll answer the questions in 2 parts. Part 1, Rudra, I completely agree with you. That horrible thing is actually, I call it SOL, space occupying lesion, nothing else. Basically, it did very well for first 6 months to 9 months, like you say, because it's a very good space occupying lesion and it's solid down there. After that, it has literally no biological function. That's why you will fail in long term. And similarly, why you say the company actually withdrew that. So to come to this case, I thought it's really, really very interesting. This is a 27-year-old now, I guess, because I saw 12 plus 15, right? Am I correct to say that? Yeah. So it's still at the prime of life and he has many more years to go. So I feel that we should try to give him a new lease of life for his knee. So first I will do EOS, long leg film, to look at how's alignment like, because I know he will have some medial joint line narrowing, but nonetheless, we get the alignment. And certainly, if I were to do any cartilage restoration procedure, then Cliff's point came in very well here, because I would do a realignment osteotomy to realign such a way, may not go all the way to the Fujisawa point, which is so-called 62.5% on the lateral compartment, but nonetheless, we would sort of try to offload the medial side, because if you do something, at least protect whatever we try to heal. So here, I guess, if this patient were in Singapore, I would really do a very nice clearance and measure the space, and actually I would do a fresh allograft. That to me is like the simplest way to get over this. However, alternatively, what I did before was actually I went in to clear all the base thoroughly. Then I will do what you call a sandwich procedure. I will bone graft the base, and on top I do a cartilage because I do have a cell lab where I grow cells and then cover the top. Yeah, that's how I approach it.
Great. Min, any thoughts on that?
No, I agree with James that it's probably heading to a valgus producing osteotomy with osteochondral allograft. I think, Rudra, at the initial procedure, OATS is challenging for a lesion that big as well, because it's multiple plugs. That might be 4 plugs, 4 large plugs, which is a lot to take from the knee. And even then, you've got the gaps between the plugs. It's not so simple. So I think it's just a challenging case to begin with. And I think the other thing with these new products is it just a kind of to really see if you're going to adopt them. I think it's good to have some skepticism, right? If it seems too good to be true, it probably is. If it's too easy for a hard problem, it's probably too good to be true. But we've seen that with thermal capsulorrhaphy and synthetic ACL and a number of different things. But I think as we see new products coming out and stem cells and other things, we have to have some skepticism and look at the data.
Good points. Well, we'll keep moving on. We've done a nice job of covering 4. We're going to hit a 5th and possibly a 6th case. And so another twist on this is a 14-year-old male, high-level lacrosse soccer athlete, and pain for about 1.5 years, occasional limp, no real mechanical symptoms, and X-ray shows the lesion, and we just jumped right to an MRI here. So growth plates are open, 14.5-year-old male, and some T1 and T2. Looks like there's probably, on the image far on your right, there's a little disruption potentially of the cartilage surface posteriorly, but not a clear breach, but a suggestion of one. Once again, he had tried activity restrictions and an unloaded brace, and after that, no signs of healing radiographically and a pretty concerning MRI. I'll just hear some arthroscopy photos, and on the left is the poster aspect, and you can see that there's a little irregularity, but with the probe in here, this lesion is completely stable. Tried to see if it would even open up like a trapdoor lesion, and it was very stable. Yeah. The anterior 2/3 of the lesion, you might see a little shadow, if you will, but basically the cartilage is intact. So about 2/3 of the circumference, the cartilage is intact, and a little buckle or wrinkle in the back, but a stable lesion. So I'm gonna, just knowing what we've seen on MRI and a stable lesion, Dr. Wee, any thoughts, drilling, fixation, bone grafting, or what would you think about this patient?
Okay, I will classify this under your trapdoor, so-called mobile but salvageable, meaning you have a very nice cartilage fragment. So I would do next is I will assess how good the base of the progeny fragment is. The reason is I want to clear the base of not so much the host bone, but also the base of the fragment itself, because how good the base of fragment will determine whether my fixation would succeed or not. So I will do an arthroscopy first, and I will free up. And I actually, in such cases, I feel that patient have a long way to go. So actually, after I done the arthroscopy, I will no hesitation to open it. I do an arthrotomy and really clear my base very well using QRAD. And after that, I would do most likely, if there's a gap, I will put in a cancellous bone graft and I will fix it. And fixing it depends on how strong I need to do it. If I feel this patient needs a really solid thing, then I will do a metal headless screw. Otherwise, I'm quite fond of smart nail by Comet.
Yeah. Well, and James, one of the dilemmas I always face is when I see a lesion like this, where the MRI is concerning, but I can't open the lesion. It's not a locked door. It's more of a locked door on the back. It's a wrinkle in the rug on the front. This is one of those lesions where I struggle to open it up when it seems relatively stable. But I think your comment about opening these, cleaning the bed out, making a fresh bed, drilling it, and bone graft, I think about that most of the time. But in this case, I think I sort of deviated from that for a couple of reasons. It was medial. It was 14.5, growth plate still open and fairly stable. And despite the MRI findings, I chose to treat him arthroscopically. And so I think, this sort of the plans, but I ended up doing subchondral bone drilling, transarticular, about every 5 millimeter interval with a 4.5 or 1.1 millimeter K-wire. And then I just arthroscopically placed 2 screws kind of along that pattern. So did not open it, did not do an arthrotomy. Just one comment about screws. I found sometimes in young patients, the bone is really hard.
Yeah.
And with the Allen head screws, one caution, especially if they're titanium, you can strip them, putting them in, and then you're going to have a heck of a time getting them out. And so I've learned that the hard way. And so I try to always use star driver screws instead of Allen head screws, if that's an option for me, just because of that stripping issue. And as Min was talking about earlier, and the importance, I think, of, you know, headless screws versus headed screws. And in this diagram, the purple is the cartilage and the orange is the bone. You really want these below the cartilage so that they don't potentially cause any damage going forward. So here's kind of before and afterwards. We look very carefully on these cannulated screws. They can be placed arthroscopically, but then I think you really want to confirm that they're clearly in the bone, and you can actually see the bone through the hole sometimes and make sure they're not potentially crowded in the cartilage. I think getting multiple x-rays to ensure you don't have anything that's potentially coming through the bone. So sometimes multiple C-arm images at multiple angles to ensure. And ironically, this kid came back to my clinic about 2 months ago. He came in with a shoulder problem. He played college lacrosse and he's a ski racer. His knee is doing fine. He's had some shoulder dislocation issues, but you can see here, 9 years later, you can see these were titanium screws. So you can see a fairly significant landmark from the screws. But if you look at the articular cartilage, it's intact and in place 9 years out. So a case I was less aggressive and got a better result than I would have expected. So
Kevin, was this a case of a trapdoor or locked door?
It was and posteriorly, it was a locked door. Anteriorly, it was a wrinkle in the rug. So about 75% wrinkle and about 25% locked door.
So strictly speaking, this actually is a stable and immobile lesion in a sense, right?
Yeah, sort of in between. I think of the locked doors as you can sometimes you can rattle the door in the hinges. Yeah. You grab it by the doorknob, you can rattle it in the hinges. So it's maybe somewhat mobile, but the anterior half was completely intact and not mobile at all. So it's sort of an in-betweener.
Yeah, but for me, what I mentioned was I thought this actually is a trapdoor lesion, because I feel that whenever I did a trapdoor lesion, the way that I, very, very aggressive, very sort of invasive, but I never regretted doing them. Whereas if a trapdoor lesion, I did anything less, by trying to get away with something more minimally invasive, I found that I always regret later.
Yeah, and I agree with that, James. And I think, Min's presentation earlier about the results of fixation of lesions, where you add fixation and bone grafting, trying to save the native cartilage, even if it isn't perfect, is probably better than a cartilage substitute. So I think going a long way to saving what they have, even if you have to open it, bone graft and add fixation is ideal. Dr. Prasad, I'd love your thoughts, because you mentioned subchondral fixation before, but any thoughts about screws? You'd mentioned Herber screws, but any other thoughts about screws, what they might be made of, types of screws, what your experience is?
Yeah, as I mentioned earlier, Kevin, my preference of fixation implant will be a titanium screw, one which is easily available in our country, and it's quite cheap and quite good. And the best part of the metal screws, or any kind of these screws, other than the bioabsorbable, what I like is the purchase, the hold on the fixation, or the hold on the cartilage, or if there is a bone, then definitely it's even better hold. So because of the threaded portion, it holds nicely, and I feel more secure with the metal screw fixation. And and depending on the area of involvement, probably I would go with as perpendicular as possible to the lesion. That's my preference. And material, I mentioned the same thing, titanium screws, and we get routinely available. And and also these screws are, if at all it has to be, when we go for removal, we can have a look at the cartilage healing, how the cartilage is looking. That is one thing. And also the parents will be convinced about removal of the implant as it is a metal screw. Yeah. So I think in all aspects, it will help me to assess the lesion which we are fixed in. So that's why I prefer these screws more than the bioabsorbable or PEX. PEX especially, I'm not comfortable with the PEX.
Right. Well, great comments. Thanks for that feedback. And Darren, we have about 12 minutes to go. I have one more case if you want us to go through it, or we can turn it over to you. And what would you like us to do?
Yeah, we can go for one more case. Yep.
Okay.
Just a question, if I may.
Yes, of course.
Yeah. So, James, we haven't heard anything from you about what's happening with the stem cell seal.
Can we don't drag into this, because most of cases
No, it's important because a lot of people in India will have somebody who's been recommended stem cell and PRP injections, and sometimes even though we don't do these surgeries ourselves, we are called upon to give a second opinion as to should we go ahead with this something and how reliable is it. So I would like the panel to comment on the role of plasma rich platelet.
The problem is people use, I think PRP probably very, very frequently used, and PRP, just remember, there's really no definite role for any cartilage lesion or osteoarthritis per se. Histologically, I mean, even in animal model, they did find some changes in terms of fluid content and all that, and in patients, certainly symptomatically they had improvement, but histologically there's absolutely no difference to the structure or healing of the lesion. So you know that about PRP. And coming to stem cell essentially, the problem now is a lot of people claim to be selling stem cells, but they don't have a proper criteria even to how they justify and what sort of criteria they use, whether they sometimes just put in monocytes and they call it stem cell. So that's why I quite like it when 2018, when ISACOS, we have a special symposium and where come the cartilage, and one of the chair actually asked me to do because of Donald Trump, they fake news, so they actually use the term fake stem cells on all those which are not being cultured or proven properly before you apply to patient. Yeah.
Right. Well, great. Well, James, thanks for the comments, and Sandeep, thanks for the question. It's something we all are hoping for good news coming forward with stem cells and PRP and other biological approaches. So, well, next case, this is Dr. Willimon's case. It's a really, I think, a really nice complex case. It's illustrating a lot of principles. So, Cliff, I'm going to turn the slide or microphone over to you. You just tell me when to advance, okay? And maybe for those of you who have your microphones on, got a lot of background noise, I encourage you, if you're not speaking, to mute your microphone, okay? Thank you. Okay, Cliff, all yours.
Great. So this is a 17-year-old male who's an American football and track high school athlete who presented with 2 months of really severe knee pain following many, many months of knee soreness after activities. His radiographs revealed an OCD of the lateral aspect of his medial femoral condyle and closed physes. His joint spaces were overall well maintained, but you can see some early remodeling of the medial compartment as well, indicating the chronicity of the problem. As part of the routine workup, his long alignment films were retained, showing slight varus alignment of his left knee as well. So obtained an MRI given the patient's radiographs and symptoms, and it showed a large OCD of the medial femoral condyle with obvious signs of instability with a breach in the cartilage posteriorly as well as in the anterior aspect. And so given that, my concern was that this wasn't going to be a potentially salvageable lesion, given the findings we talked about, the option of proceeding with salvage. But at the time of arthroscopy, it showed an unstable mobile lesion. It was really a loose body in situ. It was really just being held in place. It was already dislodged from the base and was being held in place by fibrocartilage. And this was kind of the expectation. And so at this time proceeded with both an unloading osteotomy, given his varus alignment. This was done as a valgus producing high tibial osteotomy, as shown here. The correction was done based on the preoperative measurements to pass at the fugacial pointer at 62.5%, which roughly is at the base of the lateral tibial spine, as well as performed a fresh osteochondral allograft implantation of the medial femoral condyle we can see on the next slide. So the second image to the left shows the quality of the cartilage and lesion. It was very fibrillated and unstable. This is the preparation of for the graft, and then you can see the top image from the donor as we've prepared the graft. Follow-up subsequently has shown in the next slide, the patient's osteotomy is continued to heal well and incorporate, as well as his osteochondral graft is seen to be a nice fit, restoring the contour of the subchondral bony architecture on both the coronal and the sagittal planes. And then further follow-up in June, you can see when he's weight-bearing and to look at the correction, and we were able to achieve our desired correction of unloading the medial compartment, passing the weight-bearing axis through the base of the lateral tibial spine. So I thought it was a nice case to illustrate the importance of unloading the compartment, checking the alignment, and using grafts or other cartilage restoration techniques in these more advanced lesions.
Cliff, can I ask you a quick question? During pandemic, do you have difficulties obtaining allograft?
We early on we did, but now it seems to be back to usual timelines for obtaining the grafts.
So the donors are coming back as well, is it?
Yes.
Okay.
Yeah, James, I was on the phone with the Allosource CEO yesterday. Allosource is North America's largest nonprofit allograft provider, and they actually had some drop off for a while for the first 3 months of last year, 4 months.
Yeah.
But from about April, May on, they didn't have too much trouble with getting grafts. But it hasn't been too much of a problem. But people may have had to wait a little bit longer to get the right size.
Yeah.
So, well, Cliff, that's a great case, and I think it's a nice wrap up. We've gone from you started with a nice non-operative case, and you finished with arguably one that's about as much of a major reconstructive thing we could do. The only other twist on that might be a bone grafting and a Macy or cellular-based approach other than osteochondral allograft, but that requires another surgery. But I think a really nice illustration of the spectrum of less invasive to more invasive. And so that's the end of our cases. We did a nice job of getting through 6 pretty good cases. I think made a lot of good points. And I'd like to thank the panel, the wonderful introduction with Min's evolving talk, which I've learned so much every time. And Darren, I'm going to turn it back over to you, but this has been a great experience, and hats off that you guys have done 36 of these during the pandemic. That's Chick-fil-A play of the day for you guys. That's fantastic work, and great to see you doing this, and keep going.
Yes, thank you, Kevin. Over to you, Sandeep, for the vote of thanks.
Thank you, Dhiren Bhai. So at the outset, let me thank the brilliant panel as usual, led very ably by Kev Shea, and the way he brought out the cases that there are no questions. Nobody has asked any question throughout the 1.5 hours that we have been listening to these talks. So either they know everything, it's been completely lucid, or people are asleep. One of the two. So I don't know which one. Either ways, it's been a great learning curve from me. Min, as always, has been very lucid and brilliant at the top of the order. And the cases from James, Cliff, and Rudra have been outstanding. Rudra was very good in presenting the Indian perspective and the problems that we face with costing as well as availability of implants and allografts. Yeah. So though many of us do see these lesions, we tend to most of the times observe them because they are in the adolescent age group. And I was quite gratified to hear that they do heal well and we are not doing anything wrong. And eventually, sometimes they go to our adult arthroscopy colleagues who intervene if required, as and when required. And it's been a brilliant learning all over. Thank you, guys. And these 36 webinars are courtesy all the cooperation from most of the POSNA members and people from all over the world. So like James, who's always a POSI friend and an honorary Indian. So we look forward to more cooperation from POSNA under the guidance of, under the stewardship of Min Kocher. And we look forward to more such webinars. Good night, everyone.
Right. Thank you. Thank you.
Thank you.
Thanks, James. Thanks, Cliff.
Thank
Neeraj,
you.
thanks,
Thanks, guys. Enjoyed it.
Neeraj, any feedback, Neeraj? Anything we should have done differently?
Neeraj already, I think he's bombarded with too many. I think
Okay,
he run
too many
1,000 this webinar, I think.
Yeah, well,
He run the whole
Cliff,
TV. Yeah, fantastic.
Cliff, I'll ask you anything you would have done different, then I'll have the same question to you, James. How could we have made this better?
No, Kevin, can I ask?
Yeah.
You know the term, right? We the retroarticular and transarticular. But I see some publication now use for transarticular. They use transosseous because they feel that when retroarticular, sometimes people when they come to tailors, they say what sort of term should I use? So they say if you use transosseous and transarticular, then it's very clear you are going through cartilage or going through bone. I don't know whether, have you come across such publications?
I have, and I will say that when we started this study and early on in the ROC group's kind of vocabulary phase, we went back and forth versus retroarticular, transarticular, and we finally decided we felt transarticular was clear. It went across the cartilage. Retroarticular was behind the cartilage, but the terminology is always evolving, and those are the current terms we have. I didn't mention it during the conference, but one of the challenges with retroarticular, and Cliff, I think you alluded to it, is that targeting that is challenging sometimes. And I can tell you in personal experience, I've taken care of patients who had retroarticular drilling, didn't heal. They got referred to me for second case, and I got an MRI, and I could see 6 or 7 or 8 passes, and 1 or none of the passes hit the lesion. And so I think one of the challenges with retroarticular drilling is that getting it there precisely is challenging. It's almost as if we need image guidance and robotic surgery to do that accurately, because I've seen several cases in which all of the retroarticular passes missed the lesion. You could see 3 months later, you can see the passes on the MRI, you know exactly where they are, and they weren't where they thought they were. So I think that's one of the challenges. Ben's study is going to show that actually the results of healing are higher with transarticular than retroarticular. And I think it may be because even amongst the ROC group, we may not have hit the target as well as we think. And that may suggest that even in expert hands, which I'd like to think the ROC group are as capable and experienced doing this, even in our expert hands, we didn't get MRIs to confirm our target shooting, but I suspect we may have missed more than we think, and that's why it didn't heal at the same rate. So more to come on that when Ben presents.
No, I think actually, I took away those because of time, right? I took away those slides with my intraoperative imaging on how, but I thought Min would cover them in his talk and technique. So that's why I purposely took it away, and I noticed Cliff took it away too. So it's like none of us talk about the technique, and in fact, I thought one area we should have covered is the actual technique. People will learn from us, like how where the placement of your wire, how you avoid the physis and all that.
Yeah, I think you have to be able to, you're emphasizing the importance of assessing your pin placement on the lateral view I think that's often easily overlooked because you get a lateral view maybe to start with of the first pin, and then people assume they're covering it posteriorly. But I think if you're going to do it retroarticular, you have to document, I have one pin at the most anterior aspect and one pin at the most posterior aspect in the lateral view, and then work from that. But yeah, I agree. I thought it was great, Kevin. The range of cases was perfect, and I liked having kind of pre-assigned people for each question.
Yeah,
I kept it moving well. I mean, I don't know I've ever done a webinar where we actually covered all the cases we plan to do and a bonus case and had really meaningful conversation and comments. So nice.
Yeah, I was trying to figure out how we're going to get through 5 cases or maybe 6. And I thought the only way I could do it is I have to, if you will, control the conversation and assign questions. And occasionally I pulled a few, because we actually got ahead. We were ahead by 7-8 minutes for a while. So I pulled Min in but
I think it's very good because the questions are pre-assigned. So I actually prepared my model answer here. so
I wasn't sure, some people have told me, no, the best part is to surprise the panelists, give them really hard questions. And I think there's actually, I've done that most of the times I do these things. I have no idea what I'm going to be asked. And it's kind of, you got to think on your feet and it's kind of fun. And I think you can make an argument that that's kind of fun, but in the interest of efficiency and 8 minutes per case, I figured I should just send it to you guys ahead of time and just try to, because I think that it's in some ways to cover that spectrum of cases efficiently is really, I think, good educational experience for a 40-minute thing with the audience. So I'm pretty happy with how it went, but anyway, I'm patting myself on the back. It's actually you guys did such a great job answering the questions. I just had to tee it up for, and you guys took over. So great series of cases.
Anyway, you can watch their OrthoTV. Then you can check how many views we got, because as they, as they say, well, I joke about draw Pele, certainly have the draw, here like 4,000, you could see that. And I think Ted and I did something else. You could also see like, that they had all the views. You can see like 2,000, 1,000. So you can see like how popular your session is.
The only person who logs into my views is my mom and my dog. No one else watches my cases. So, it's great seeing you guys at various different hours across the planet. So, James, I think you got to go to bed now, right?
Yeah. No. I actually, this one I'm a bit later. Unlike I just did my we would do our Davos course and to suit the Europeans, and then the European always 2 p.m. and poor Daniel Green had to wake up at like 5, and I have like quite nice 8 p.m. So yeah. So Cliff, you're in Atlanta, is it?
Yes.
Yeah, okay. Oh, that's one. Kevin, that's one of the very few cities in US I haven't been to. Okay, I will make a trip next time.
Okay, add that to your list.
I have to come visit. I will. We'd love to have you.
Yeah. I mean, I'm like, I literally been to like, last count, I've been to like 36 cities in US, and I've been to more Indian cities than any. Actually, the only good thing about this pandemic, my wife said, finally you're at home.
Yeah.
I like your Prism certificate in your background. Good. Good marketing for Prism.
That was the plenary speaker I went to, and then so I put all my stuff just at the back of the office, and then that is a nice virtual background to show people that I'm in the office all the time, so that people actually can't tell the difference, when you're in office. You know what I mean? Just like you, are you using a virtual background or no?
This is, I know, my regular office. This is my office.
This is real background, right? So, but imagine if you take a picture now, and then you go everywhere, people will still think that you are in your office. Yeah.
Maybe I need to take a picture of the beach or the mountains.
No good. Everybody think that way.
Thanks,
so you have your vaccination as well, is it, Cliff?
Yes.
Okay. Yeah, that's good. So yeah, all. Well, I had zero response, on vaccination. So I don't know whether I'm too old to have zero. Kevin, nothing, no pain, no fever, no nothing. I work the whole day and nothing happens. So.
Great. Cliff, how are you guys doing with COVID in Atlanta right now? You guys doing okay?
Yeah, I think the numbers are finally stabilizing and declining. You know, it was interesting because in Metro Atlanta, people were much more responsive early on to precautions of masking and distancing.
Yeah.
But when you went to the outlying areas, you would walk in to the store, a hardware store with a mask on, and people look at you like, what are you doing? And they don't have masks on, and that persisted, and those are in the outlying areas of Georgia. And then that was when the second wave came through and really affected a lot of the smaller communities. And so now they're kind of on track, but it's really the hospitals are well staffed and their ICUs have expanded. So from a capacity wise, we're okay, but it's too many cases.
Yeah.
So Kevin, do you think the POSNA in Dallas is going to be on?
You know, right now, I think no, because I think enough academic centers are not going to let people travel just because the concern, at least at Stanford, is the number of variants that are emerging. And right now, I'm not allowed to I may have to sort of go secretly, but Stanford is not allowing us to travel till January 16th at the earliest for professional work. And so if I go, it's my last year on the board, so I'd kind of like to be there for some initiatives that I've been doing with the board. But right now, Stanford doesn't want us to travel. And I don't think they're going to forbid us outright, but they've strongly discouraged it and they won't support it financially. But they don't want us to travel, partly because California's had a real problem and there's concern about bringing the variants back to the state. So I don't know, but also, our cases in the United States, the last 3-4 weeks, cases have dropped dramatically, including daily positive tests and counts. We were hitting 400,000 cases a day. And yesterday, I think we hit 63,000. And we're under 1,000 deaths a day or 1,300 deaths a day, where we were hitting 3,000, 4,000 deaths a day. But I think, it's barely 3 months out, right? So we'll have to see. Maybe herd immunity is going to come a lot faster than we think. But right now, Stanford has said June 16th is a hard date. They are not allowing any travel before that, no matter what happens. So I don't know. What do you think, Cliff?
Yeah, the Emory and Children's the same in that they will not. So you can travel, but it won't be supported travel or funded travel. And so my concern, the vaccine rollout, at least locally, it's been really slow outside of healthcare. And so even for, my mother is 79 years old, and if I wasn't able to help kind of direct her to where to get one and to find that was available, it would have been very difficult, if not impossible. And she's fairly technologically savvy. So.
Okay.
So do you think they will run on a virtual sort of Zoom meeting kind of thing for POSNA?
Say that again, James.
Do you think they will run on a virtual like Zoom meeting kind of thing?
Yeah, they're going to have a dual format this year. They know that some people won't be able to travel, so their plan is to have a dual format. The question is it one format because they can't go? I think there are going to be a small number of people who can go, but the problem I think for POSNA is that the bill for the hotel will be really high if they have 50 people, and the finances of that will dwarf any revenue they get for it. So if POSNA doesn't get a certain number of people, they'll lose hundreds of thousands of dollars in hotel fees. And right now the hotels know that it may be canceled. And so if they cancel it outright, the POSNA is not going to be out much money. There may be a little bit of a deposit, but if they go forward with the meeting and 50 people show, they'll probably eat hundreds of $500, $600, $700,000 in hotel fees and not have clinical revenue to match it or attendee revenue. So I don't make that decision. I'm glad I don't, but that's going to be a tough decision.
I'm a little bit upset because I actually have a best paper shortlisted for podium. Not every day you get a finalist paper, so I'm like, shucks, so I must fall on the year. Maybe.
Yeah. Well, there's always next year, right?
Yeah, I should have submitted next year, not this year. Okay, great. So I see.
Good to see you guys.
All right,
again. See ya.
Nice talking to you again. Take care.
Bye-bye.